the meeting. Welcome everyone to the first meeting of the Health Overview and Scrutiny Committee. Could I have nominations for chairman, please?
I'd like to nominate Adrian.
Thank you. Do we have a seconder? Do we have any other nominations? Okay, Adrian, you are now chairman. Would you like to take over?
Thank you very much for the nominations. I'm happy to be your chair again. Hopefully we'll have a good year this year. The second item is to appoint a vice chair. Do we have any nominations? Beth?
I'd like to nominate Rochelle.
Thank you. Do we have a seconder? Al? Thank you very much, Al. So are there any further nominations for vice chair? Okay, thank you everyone. So Rochelle is elected vice chair for this year. Madeline, do we have any apologies?
No.
Can we confirm the minutes of the previous meeting on the 27th of March? Is everybody in favour of that? Carried, thank you. Do we have any declarations of interest? No. Are there any public questions? Member questions? Next item is a presentation on continuing healthcare. This should be Alison and Andrew. Oh, it's Building Berkshire Together, sorry. Sorry.
Hi.
Andrew, do you want... Hello,
Hi,
thank you.
I'm
Thanks a lot for joining. I'm not sure who's presenting first. Is it you, Alison, or is it you?
Yeah, Alison's going to lead for us.
Okay, we're all ears, Alison.
Okay, thanks everybody, and congratulations to those who are new. So I know it's hard work getting here, so congratulations. I have sent around a slide deck. I don't know if people had a chance, but is it okay if I share that here and talk through the slides?
Yeah, absolutely. But we would prefer you to kind of go a summary of each slide rather than go sort of verbatim. It's a little tedious, because we assume that the committee members have had a look at your slides already. So if you could give us, key points to take away, that would be great.
Yeah. Okay. Perfect. Hopefully you can see that on the screen. Are we there? Yeah. Just very bit of background. We are on the new hospital programme.
Sorry, it's a little small. Could you maximise it? Is that possible?
Sure. How's that?
That's perfect. Thank you.
Great. Okay, thanks. So we're on the new hospital programme since 2019. As part of the government programme to deliver 40 new hospitals by 2030. We did a strategic outline case. There's three stages. You submit a case for change, which is strategic outline case. You then do a full outline business case, which does a lot of analysis and appraisal of a short list of options to get to a preferred option. And then the full business case is where you, I guess in summary, go out to contract for your preferred option. So we've done the strategic outline case and submitted that, and we've started work on our outline business case. Now, being part of the new hospital programme, just to say, this means we're in cohort 4, so there are a few hospitals before us, and it means that we are what's called full adopters. That means that the way in which new hospitals are going to be built in the future, starting from now, is through standardised designs, centralised processes. So if you've got 40 new hospitals, we want to deliver economies of scale by doing things once and sharing them, those kinds of things, and using modern methods of construction, for example. So that's the theory behind the new hospital programme, and we're in cohort 4, which means we should adopt the principles of the new hospital programme. The New Hospital Programme team have been making the progress on their business case. So they've gone to Treasury. They had agreement for the full programme in March, and that was announced. People may be aware a couple of weeks ago, the Secretary of State for Health announced the total programme budget to take us up to 2030, but also indicated this was the new way of doing hospitals going forward. It's a complete redesign of how hospitals will be developed in the future. So it's part of the start of a rolling programme. You will have noticed that there are some hospitals that have been added to the programme, to the original list, and they have got some significant issues which need to be addressed sooner. And that may have an impact on some hospitals being delivered slightly after or after the 2030 deadline, the ones that were already on the programme. So we're not sure yet about that in terms of the scheduling. We need to have a one-to-one with the New Hospital Programme team to look at our plans. But it may be that some hospitals who were planning to deliver before 2030 have a slight delay to their delivery because of those additional schemes, and because actually, if we were all with the additional schemes and all going out to have our hospitals built at the same time, the supply in the market would really struggle with that. So there has to be an element of phasing and consideration of different hospitals are on different stages of the programme. Our funding envelope has yet to be confirmed in writing, so we're expecting that imminently. We know that it will reflect that as part of a new hospital programme, some costs will be kept centrally, and there will be expectations that there will be some savings on our original estimates. So as I said, we will be meeting with the new hospital programme to talk through, and it's a bit of technical language there, minimum viable products. So we will be reviewing our proposals that we submitted, looking at how we can deliver those proposals through the new hospital programmatic approach. And so therefore, what does that mean for us in our funding envelope? But as a result of the announcement that was made, we have started to see now the programme starting to move forward. So we submitted an enabling bid in August last year, and we've been asked to update those in terms of costs to reflect things like inflation and other costs. Are they the same as they were when we submitted them in August? So and that's got to be submitted fairly quickly. So we started to see things accelerate in terms of our progress. What we've been doing locally with the budget, and I say limited budget there available, going back again to the way that we deliver the new hospital as part of a programme, is that the idea is we don't design things separately as individual hospitals, but that's done. We have a standardised design, so there's been restrictions on what we've been able to proceed with, and the budget available to us. But within that available budget, we have been proceeding what we can do at a local level that can't be done nationally or standardised, and that's looking and working with our population, with our staff and our key stakeholders on developing a short list of options. We had a massive response really to a survey that we ran between January and March. And we've been trying to hone down on our short list of options and finding out what's really important for patients and for staff to help us with that shortlist process. And then what we do with that shortlist once it's been approved is we then invest a resource in analysing and appraising those to get us to a preferred option. So the results of the shortlisting so far, so we're still that's still going through a process of validation and talking to various different stakeholders about that. I think Sarah's on the line here. We've got a discussion with Berkshire West UAE this week to talk through our progress on those. But we've got two leading options, and interestingly, there's a lot of free text in the survey, and there's quite a lot of comments made about what else should be part of the hospital and what would be helpful to be part of a hospital or co-located with a hospital. So very high was comments and responses around mental health services as an example. So we're working through those responses and looking at what are the opportunities with the investment that we get from the new hospital programme to work in a more integrated way, which I think everybody wants to do. So it aligns with our strategy, but also aligns with the ICS strategy. So we're having those discussions now with our stakeholders. We are also exploring alternative sites as part of that process, and I've listed here that there's two that has in the first run of that shortlisting process has been the closest to meet the criteria that we set around looking for a site. It's not that easy, as you might imagine anyway, to find a site near the centre of Reading or in and around where we are now. So the two sites that have come up at the moment that need much more work to see if it's affordable, if it's got the right access, how long it would take to build on those sites. That's the work we'll now do going forward in much more detail. Now we're progressing. So those are on the Brownfield site is Thames Valley Park, and then Thames Valley Science Park is a greenfield site. So I've listed there just a number of next steps that we're going to be doing. I talked about the shortlist, and we need to do a full appraisal process to get to a preferred option. We will be involving the public and key stakeholders in that process as we hone down those options. So it will take a considerable amount of time over the next year to do that. We'll work with the new hospital programme on understanding what does our funding mean for us and what is the minimum viable product hospital for Royal Berkshire. What does that mean? And they're calling it 2.0. Those are the kinds of hospitals that will be built through this programme. So what does our hospital 2.0 look like from the programme? We're going to review and update our strategic case that we made. Oh, apologies for a bit of a typo there, but it was strategic case. So that was submitted a couple of years ago. Are there things that we need to add into that and update any costs? We'll be working with system partners on the next stages of developing our clinical model, and see what this opportunity could bring to the whole system in terms of its investment and opportunity to look at some real transformation and benefiting from some scale of that investment. We absolutely maintain regular engagement with public, and we're going to increase our engagement in a targeted way in areas that through the survey we found were underrepresented, so some groups that were underrepresented, so we're going to increase our efforts in those areas. And that survey was really helpful for us to understand who we're reaching, how we're reaching people, and where we need to focus our attention going forward. And we're going to progress enabling works. So for example, if our minimum viable product, our new hospital 2.0, can we build that on our current site? So there's a load of work that has to be done to evaluate and assess that. Developing digital and capacity and capability to enable our moves. So as an example, so our data centre that we have on the site, we know that we have to move it. So we're just looking at, where do we need to do that, but need to move that going forward, and things like using cloud much more efficiently. So wherever we move, if we move or whatever we do on site, that actually we're in a digitally strong place to do that going forward. And so look at the exploration of potential benefits of investment in wider estate. What I mean by that is the reference I've made earlier to the discussions with the wider system around how do we support and enable greater transformation and integration through the investment we get from the new hospital programme. So I'm going to stop there. Hopefully that's a good skip through, and I'm open to any questions.
Rebecca.
Thank you. It's interesting to hear about you talking about engaging with stakeholders. I'm well aware that you had a meeting recently which wasn't hugely well attended. I mean, I didn't attend, probably should have done. There was an outside meeting. So I'm just wondering how you're going to get people to come along to engage as stakeholders, because it's quite a difficult task getting people's opinions, isn't it, and meet with them.
Yeah, so we We learnt quite a bit from our engagement in the last few months through the survey and through the events. We had one in Wokingham. It had about 30 or 40 people come to that event, but we got some feedback around targeting events at different times. We run an online event every month to update anybody who joins, and they're all promoted on our website. So we have a regular update session for anybody to join, but when we do some more targeted events, we'll be learning from where did we have a good turnout and why, and what was the feedback that we got from that. I mean, we did work quite closely with Healthwatch. I think they're on the line. We worked closely with Healthwatch to try and maximise our engagement in different areas. Sometimes it works really well, but actually sometimes it doesn't. So we will learn from that. But we've got a lot of from the surveys. We've got a lot of feedback from Wokingham stakeholders, so that's helpful as well. But it doesn't end there. As I say, the next year is actually going to be much more engagement on that front. And if you've got any guidance tips around that, we had some at the event that we attended. We met with some local leaders who said they would share things with their networks. And we've built on our networks from doing those events. So I think I'm optimistic about engagement going forward. And the survey response is quite good for 3 months to have over 3,500 people respond. So,
Rochelle?
I can't hear anything. Is somebody speaking?
I was at the event with the cricket club.
Yes.
And it was myself and one other councillor, and that was all that was there from the council, at least. But among other things, one of the things that was mentioned was the chalk mines underneath the present hospital, and how it was very difficult to shore them up to be able to put newer, taller buildings in that area, because they were thinking about making up flats there or something like this. And the other problem is the listed building. Part of the hospital. You can't do very much to that. It seemed like Thames Valley Park would be a better place because it would be less. It's near motorway. It's near Reading. It's not that far from Reading, and it sounds like a much better location because you could actually get ambulances there somehow or another without having to go through the normal problems in that area. That's one of the things I'm looking at. The second problem I was listening to was that recently they have announced that the Royal Berks was one of the hospitals that was not going to be built as soon as the others. It was going to be delayed. And I just wanted to know if you had any comments about that. It was in the Times, it was in a few other newspapers about that they had planned that was one of the 2 or 3 hospitals that weren't going to make the grade right now. So just wondering how that's going to affect everything.
Yes, thank you. I mean, one of the lovely things about being in the Royal Berks is the history that we've got linked to it, and the listed building. And there was a discussion around that, and there were quite a few people who had some good knowledge around the history of it. What we're doing at the moment is we're doing some surveys of the site. We're trying to understand what we've got on the site and if it's capable of building better, building bigger. There are a load of other things to consider in terms of that site. It's quite landlocked. It's surrounded by either a conservation area or residential area. So the scope to, for example, if we wanted to build bigger, would be only to build up, and therefore there might be some planning issues, and so those have to be looked at. So there are. And I think the Secretary of State's referenced that there are issues with looking at and our site at the moment that we're having to investigate. So we're not in a position to say at the moment, whether we can build on there or this new type of hospital, or whether we should be building elsewhere. And you're right, it sounds like at face value that the Thames Valley Park it's just down the road, and it seems like it might have good access, but actually until you start investigating some of these issues, we won't really know, and that's the next start of this process. So all options are being explored and need much more detail for us to make a decision on them, but we will engage and keep people engaged going forward. The second the second point you made there, Oh,
The second point was the chalk mines under there, but it's also the fact that the Thames Valley site, or Thames Valley Park, would be a better site as far as that goes. But another question might be that they also mentioned something about making Woking Hospital a rehab hospital also as part of this program. I was curious if that's actually part of it or not. This is what one of the people in there who gave the presentation talked about, so I can't tell you whether he was supposed to talk about that or not, but
yeah, in Wokingham, I gave the presentation. I know there were some people in the room talking about those issues. Wokingham as a rehabilitation hospital, again, those are things when we talked about using our estate, what are the things that we could use our current estate for? How do we work in an integrated way? We need to look at those options. Our clinical services strategy is wanting to deliver services much closer to everybody, not just much closer to people in Reading. So we are looking at all of those options. So so that they're not off the table and they are part of our discussions. That's what I would say. There's and it hasn't been decided that we will be doing that. So there is scope for influencing that.
Just for clarity, Woking Hospital is run by Berkshire Healthcare Foundation, just as part of the community services. So we'll absolutely work and discuss with them these plans, and that's part of the discussion that Ali was alluding to on Thursday, that we're starting with partners through the Berkshire West Integrated Care work.
Al?
All right, thanks. First, I mean, I was always told that the London Road site, if it no longer was a hospital, it would revert back to the estate of the family who donated it. So is that actually true, or is that just an apocryphal story?
There are a number of covenants on that site. It was gifted to us for healthcare purposes. So absolutely, we need to look after it and use it for healthcare purposes. The definition of that could be quite wide, but we've got a piece of work at the moment. Firstly, making sure that we understand all the covenants and the implications of any changes to the site before we make any decisions on it. So yeah, that's it's certainly up to us to maintain that grade 2 listed building.
And so can I just ask about, because I mean it was only a few years ago that the Battle Hospital site was closed and sold off for housing because the London Road site was decided it was sufficient. So it's only a few years now that we're saying the London Road site isn't sufficient, and we've lost a large site in Reading, and also what happened to all the money when they sold it off.
I can see Andy reaching for.
So I think that the Battle coming together of Battle and what was the Royal Berks was 2000. I'm sure people will know that better than me. So that's approaching a quarter of a century ago. I think that the challenge that we've got with the current site is not that we can't deliver the services that the population needs kind of from the geography. It's just that the condition of the buildings, including those that were built 25 years ago, but particularly those that were built much longer ago, are no longer fit for modern healthcare. And the challenge that we've got is, can you redevelop the site whilst maintaining a fully functioning acute hospital that our citizens and residents need at the same time? And is that the right thing to do, or is it right to seek another site where you can build and move to? But that also comes with many of the other challenges that Ali was already alluding to.
Okay, thanks. And can I just ask then, has Green Park been eliminated because of the Burfield atomic bomb factory? Is that the reason why the Green Park can't be considered as a site?
So there are greater risks with Green Park. So it's not been eliminated, but it hasn't scored as well as other sites because it is now part of a widened evacuation zone. So you're right there, but we haven't crossed it completely off the list. It just carries more risk at the moment.
Beth?
Thank you. Will having 2 sites be part of the consideration so that you can retain some services on the current site, which for parking and transport is a nightmare, and take some services out to relieve pressure on that site?
So how do we answer that? We kind of see ourselves as having multiple sites, so we don't. Yes, it's possible that we could explore in Reading in particular, maybe looking at having other sites situated somewhere else. So that is part of what we're looking at, and we've got our other sites that we have been increasingly using for things like outpatients, diagnostics. A whole range of treatment in Bracknell, in Henley, and in West Berkshire hospitals. So we kind of see that we've got more than just the one site, but in terms of the site, the services that we're currently delivering in one site, we are exploring if that can be delivered either through other sites, or do we need an additional type of facility in Reading as well. So we are looking at those as part of the options.
I feel.
Very brief. There's 2 things. Firstly, very, very interested to hear your input, but I'm afraid I don't know who you are. Perhaps you could tell us your involvement in this, because that would be good for the record.
Sorry, I'm Andrew Statham. I'm Director of Strategy at the Royal Berks.
Right. So you're involved in the rebuilding.
Yeah.
Okay. And the other question, I have actually is general. Has there been discussions across Bob, which might involve any specialisation at Royal Berks, which might direct some of the building, or is it just going to be built around a general hospital basis?
So I'm going to answer that. So actually, very specifically, our investment with the new hospital programme must deliver benefits to our wider system, and that's something that we want to happen as well. So we have been talking to the wider system around these plans, but it's been an early process. It's really hard to move things forward until we're clearer on the funding envelope to move things much further forward, but we have been having those discussions. I see Sarah's come on the screen, but absolutely we are talking with our wider Bob system, but also Berkshire West locally. We've been talking to Sarah. You've got your hand up. Sorry, I don't want to interrupt.
Hi, Chair. If I may come in on that one as well, oh, excuse me. I'm Sarah. I'm the Director for Berkshire West within the Bob ICB.
Sorry, we can't hear you, Sarah.
Can you hear? Is that any better? Is it completely mute, or can you just hear me quietly?
It's
Quietly.
very quiet.
Oh, sorry about that. I'll start shouting at my laptop screen and see if that helps. So I'm Sarah. I'm the Director for Berkshire West within Bob ICB. So we have, as we've mentioned, we've been having a lot of conversations here within Berkshire West around this programme, but also that there are conversations between the acute hospitals across Bob to discuss areas where it makes sense for them to collaborate and work together, whilst also retaining the absolutely fundamental services that we need locally within our local hospitals as well. So I can provide the committee with assurance that we are considering this from both angles, from strategic angles, and also discussing with other ICBs. So Frimley being a key one as well. Obviously, that's another, and Hampshire. Our hospitals are also very close, so we need to make sure that our programmes are coordinated.
Rochelle?
A couple of questions. Will the new hospital be a teaching hospital? And the fact is that both Reading, Woking is the largest population centre in Berkshire right now. It's bigger than Reading, but between Reading and Woking, a hospital would be a very good idea, because we have a large number of people. And it's a teaching hospital. We might have some specialties, so you don't have to go all the way up to John Radcliffe or something in Oxford.
So a key part of our strategy is how we work in medical education, and we're really active with in receiving students from Oxford and from Southampton universities. We have been in discussion with the University of Reading about our medical education work. At the moment, that's not their position, that they'd like to go as a standalone. But medical education is a real key part of what we're doing, and we'll work out how we, and we're working on how we pursue those ambitions, because a workforce for the future, both doctors, nurses, and other professionals, is really important to providing the care that we want to.
Any further questions? Just a general question. Do you feel that there's real momentum in this now? Do you think, because I've seen many presentations on this topic, and it's always felt like it was just out of reach, but I noticed one of your wordings said that written confirmation was, imminent. So do you feel that there's real momentum building?
Yes. The confirmation at government level, so the agreement between the Treasury and Department of Health and Number 10 around the funding envelope, was a massive milestone to move forward. So and that was agreed kind of just in March, and now it's been announced. It's yes, this is now happening, and we've started to have workshops around what that means as part of the programme teams. We've been asked to submit proposals for enabling funds to move things forward much more quickly. So we have seen a lot of activity and things being kind of released over the last couple of weeks. So this feels very much like now we're starting to pick up a bit of pace and accelerating our progress going forward.
Just one further question. It's very encouraging to see sort of standardisation and MMC, and this idea of perhaps prime contractors moving from one hospital to another hospital as they're coming online, as it were. But I was a bit confused by the idea of staying on the current Reading site and then adopting a standard Hospital 2.0, which would have to be then reconfigured for more layers because the site is constrained by boundaries. I didn't really understand that.
And that is the work that we're going to have to do next. So now we've got kind of, we're closer to understanding what a Hospital 2.0 looks like, what some of the standardised designs are, and what some of the policy direction is around what rooms we've got, and what sizes they need to be, or what sizes wards need to be. So we have some very clear direction in terms of what that needs to look like now. Therefore, we need to work on, is that possible on our current site and deliver great services that we want to deliver? So that's the piece of work. Now that we've got that clarity around what Hospital 2.0 is starting to look like, can we do it where we are? And can we do it while delivering services? That's the piece of work we have to do. So yeah, I mean, we're asking the same questions as you, so we're on the same page.
Thank you, Alison. Any further comments, Andrew, Alison?
I'm good. No, thank you.
From the committee, thank you very much for your time. Really appreciate the update. Please keep us, in the loop, as it were, and very good luck with everything. And I hope it goes really well. Thank you very much, both of you.
Thanks. Bye-bye.
And thanks a lot, Sarah, as well, for your intervention. And the next item is GP contracts, and this is going to be Sarah and Abid Arfan, if I've got that right, hopefully.
Yes, hi. Thank you very much, Chair, and thank you for inviting us back again to the committee today.
Sorry, Sarah, you're really quiet again.
Sorry, do let me know if it drops out again, and I'll do my best to speak as loud. I think there's a problem with my microphone, but I hope that's okay. So I'm joined by colleagues. So Abid Irfan is the ICB Director of Primary Care, and Helen Clark is our Head of Primary Care here across Berkshire West, which covers Woking and Reading and West Berkshire. So I thought it'd be helpful for them to join me as well today, as they're subject matter experts in this area. And Abid is also a practicing GP as well, so has experience from a range of angles on this. So we've been invited today to talk about the GP contract and what it means for residents of Wokingham, particularly in light of a number of the national announcements around this. And Helen has kindly prepared a detailed slide pack for you, which I know you've all had a chance to read in advance. So just to touch on some of the key points from that, and then we can open up to questions if that's okay, Chair, and that's where my colleagues can support as well. So the contract is the last of a 5-year agreement. So it's not so we're talking about a variation to an existing contract rather than a complete rework this year. And there are a number of changes that are outlined in the slide pack, but the key ones focus on improving access to GP services for our residents. So what exactly does that mean? So there's a focus around making sure that we're able to assess the need or signpost to other services at first contact. So people aren't asked to recontact their local practice again a second or third time to try and access an appointment or other support. And a focus on making sure we're able to provide a same-day assessment of need if there's an urgent need, and also an appointment within 2 weeks for non-urgent primary care need. So there are some of the core things, and there are more areas within the slides that we can touch on if you've got any questions on those, but that's the crux of the real improvements that nationally are being asked of primary care. So how might we do that, and what does that mean for Wokingham? Well, we're already delivering a fairly strong position in Wokingham with regards to sort of 2-week access to appointments, with 86% of appointments being offered within 2 weeks already, of which just over 50% of those are on the same day. So we're not starting from scratch, and I know colleagues in across the GP practices across the borough are working really, really hard on this to make sure we are delivering the right level of access and care for our patients. And so other areas of focus at the moment are around improving telephony in all practices. So no one should receive an engaged dial tone when they call to speak to their GP. They should be able to be in an intelligent queuing system that keeps them briefed as to how long their wait may be before the call is answered. Again, a large number of our practices in Wokingham already have this advanced telephony, and we're looking to enhance that and further roll out to make sure that it's accessed by all. Also looking at online platforms as well, although noting we do still recognise the real importance of face-to-face clinical appointments where those are needed as well. So wanted to provide a level of reassurance around that as well. We're looking at recruitment as well. So the contract allows for flexibility in a range of roles that can be recruited into primary care. So we have previously spoken to the committee about the additional roles reimbursement scheme, where funding is available to practices to reimburse them for a range of clinical roles that are appropriate for different contacts from our residents. Again, there's a nice pie chart in the slides to show the range of roles that are available to our residents in GP practices already. And the good news is that the contract allows for even greater flexibility in how we deploy that funding going forwards to make sure we are able to fully utilise, or continue to fully utilise, I should say, as we've been very successful in recruiting here in Wokingham using that funding to date. And also there's the National Workforce Plan and pension reforms as well, looking at how we can retain the existing workforce predominantly that we have in place. So there's more information on that due in terms of the National Workforce Plan that we are eagerly anticipating. And then there's also a big focus on how do we remove the non-value adding steps that are currently using a lot of time of colleagues in primary care. So, for example, looking at how we can use other appropriate settings and other appropriate professionals, such as our community pharmacists, to take on a level of work that's currently going to primary care, but to GP practices, but our community pharmacists are very well positioned to do that. And that you'd have seen that in the national news as well, around the announcement announcement for that. How we can look at self-referral routes, so people who are currently going to their GP practice and then are on fairly rapidly referred onwards to other services outlined in the slides without much intervention from a GP. What can we do to make that a bit more of a streamlined pathway so that it's not taking up unnecessary time of a highly valued staff that don't need to be doing something when we can just have self-referral pathways instead. So there's a lot of work ongoing. And there's also some a mention around better coordination with local authority planning departments, although I would say here in Wokingham we do have fairly strong links into the planning department that we're strengthening as well. So there's nothing of note here that we'd want to highlight as a concern, but it is just always helpful to note that when any local authorities are considering their local housing plans, that the health needs and GP needs of the residents of any new developments are taken into account as well. So the next steps are each of our GP practices are developing their access improvement plans this month that we'll then be considering and working on how we support with that. And as an ICB, we are developing then our overarching access recovery plan that I believe is going to our board in the autumn time. Abid will correct me if I've got that wrong. And then we'll go from there. So I suppose at this stage it's an update on what it may mean, and we would be very happy to come back at a later date when there's more concrete detail in how we're going to be delivering that. But I hope that's a helpful overview, and thanks again to Helen for the information in the slides. And Chair, we can open up to any questions if that's okay with your good self.
Any questions, Phil?
I saw lots of interest in waving body parts when you mentioned access to healthcare for people and residents of new estates in the Wokingham area and developments, which has probably been one of the tragic failures of the health service in this area to date. We've got a very large central practice in Wokingham, which has had its issues, and everyone, they're entitled to have their issues. However, there's constantly been beat back about the possibility of remote or satellite sites, whether for that practice or for a new GP practice. At what point, where is the tipping point at which the local healthcare commissioners are going to accept that people can't get to a GP close enough to them when they're unwell, and they have to then take the opportunity to perhaps build some additional facilities more local to those estates?
Thank you. Helen, would you want to come in on that, or I see Abby went to come in initially around because I know there has been a level of conversation to date, and where we are with that at the moment.
Yeah, I mean, if I can just respond, obviously this is a matter that we've discussed historically on a number of occasions over a number of years. As Sarah mentioned, so the CCG's previous estate strategy highlighted that there was capacity for residents moving into new estates. There were a number of premises developments undertaken through national capital funding that became available to support practices to accommodate those patients. I think we are now at a point that as the council reviews their local plan, we need to work with the planning department to refresh our assumptions around future population growth, where we're at in terms of existing primary care capacity and what that means moving forward. And we are already in regular discussions with the planning leads around those matters.
Yeah, I think I'd just like to add, I mean, you're right, and there's been a significant expansion, and certainly in Wokingham as there is everywhere. And I think we just need to be better at planning together, moving forward when there's new developments, so that we're not constructing without making sure the infrastructure is there. And the other thing, Sarah's alluded to all the other things we're doing to make sure we've got the workforce as well. So it's not just estates, it's making sure the workforce challenges are addressed. So Sarah's kind of outlined briefly, there's a number of actions we're taking, especially to retain GP colleagues and nursing colleagues, at the beginning of their career, make sure they're coming into the profession in the first place, but also retaining those, making it easier for those who are thinking perhaps, maybe I'll retire in my early 50s or mid 50s. 10 years, 15 years ago, it was unheard of. You'd work on 65, 70 plus easy. but now it's a whole different ballgame. So we just got to make sure that we're getting that absolutely right. But I think joint working and joint planning is really going to be the key going forward. And as Helen said, I think establishing, making sure those links are there for future developments, and working in different ways as well. So perhaps new surgeries everywhere is not the answer. We've got to think smartly. We've got to think cleverly. We've got to think, what is the best way to deliver the ask of the new healthcare services in the new world for those patients. So face-to-face may be appropriate in some instances, but we can do a lot through smart technology as well.
Can I just add, Abid, that our primary care networks have just been engaged in a piece of work called the Estates Toolkit project, which is looking at their existing capacity, also in with reference to those sort of new ways of working that Abid's mentioned. So I think that will be a really important starting point as we go through the local plan discussions, in terms of informing us as to what the starting point is now, and what will be needed going forward.
I think Alice wants to add something.
I think most of them know what I'm going to say. Just to share with you that part of our work plan in going forward has been about GP access and GP qualities. And one of the things that we have been looking at has been that people don't know how the new way of working. So I do think as much as you guys have this new workforce, but the public does not know what they do. And, this is something I think comms needs to work a little bit more so that they understand what is happening. And as you said, work smartly, but we could help. The public could help you all by, if you all could tell them what is going on, who does what, because the perception has been I'm going to see a GP. Well, actually, that's not going to happen, but there are other people up. So I do think there's a little bit of comms that needs to happen so that people understand what the roles are in the surgeries itself.
Yeah, you make a really good point there, Alice. I think it's spot on. So, it's still new to a lot of people, but there's so much, for example, the pharmacists can do. There's going to be a whole new program in Pharmacy First coming on stream if that gets funding agreed with the General Pharmaceutical Committee. So that'll change. It'll be a new kind of whole new era of kind of all these additional healthcare professionals doing the work and assisting. So, but you're right, we've got to get the comms right. So our patients and communities understand exactly what they're not getting a lesser product. They're just getting it's being seen by the right professional at the right time. That's the key thing. And the GP colleagues can then concentrate on our aging elderly population and all those complex patients with really complex problems, which, 10, 15 years ago, we didn't have so much, but now we've got massive increasing kind of aging population, more people with multiple problems. For example, they might have COPD, airways disease, heart failure, diabetes, kind of all wrapped in one. And so we need to focus, working at the top of your license is the phrase that we kind of use in the profession, making sure you're working best, hardest for your patients, seeing the right professional.
Sarah?
I think just to respond to Alice, you must be advising NHS England because they are working on a national comms campaign on exactly that. So that will be very helpful. And then we'll see what we need to do to supplement that locally to make sure that it's reaching everyone that needs to hear and understand.
Rebecca, please.
Just very briefly about you talking about the local plan. We know what's happened with these large housing estates, and Phil has touched on it. We've got a huge estate out in Arborfield where there was a GB service that was planned. Lots of my residents are affected by this. We've got thousands of new houses. And I appreciate you're talking about pharmacies and other accesses. They don't even have a supermarket. They have a co-op. So they have nothing. And the only way to access anything is to get in a car. So you say you're going to look at the local plan. Well, there was a site in the local plan. There was originally a surgery plan for that site. And we're now years down the line, they have nothing. So it's just an observation can we keep making these mistakes, planning these large SDLs where we've got no facilities for residents?
Rochelle, please.
Several questions. One, you're talking about pharmacies. I'm in a town right now that has no pharmacy anymore because the last Lloyd's pharmacy left. And a lot of the smaller pharmacies, which you used to be able to go to, don't exist anymore because of different problems. That's problem number one. Problem number two, they haven't really put things like new GP surgeries in the local plan. I worked in the local plan before this, and everybody would ask, why don't we have one? And we have to tell them because they're all private contractors with the NHS, and they decide where they're going to go. We can't tell them to do. Even if we have a site that we prepared for them, they won't go. So that's another problem. What are you planning to do about that? And as far as planning goes, planning has nothing to do with the NHS as far as this goes. Planning, you may have some discussions with planning, but they don't seem to actually go through to the planning committee or anything like this and understand where these new surgeries are going. We haven't seen that many new surgeries in Woking in a very long time. And yes, we've put in thousands and thousands of houses, probably close to 10,000 by the time we finish the next local plan. And we need significant number of new GP surgeries in this area. We are the largest population area in Berkshire. We have the least number of surgeries compared to the other larger areas. What's being done to help us?
You've got a question, Tony?
Sorry, I was just going to ask, we are getting the ARS extra professional staff, but I think with the ageing population and the building we're doing, we will actually need some more GPs. Are we actually recruiting for GPs at the moment?
Yeah, you're right. I mean, so locally in Thames Valley, the registrar kind of posts, that's the training doctors who we hope will stay in the region, are absolutely full. So they've increased the number of spaces and they are all full. So I think, Helen, you may have the figures to hand when we looked at this recently, but full-time equivalent, number of GPs, we don't do too bad compared to the southeast. It's just there is a variation across the patch still, despite that. But we've got to. You're right. We've got to get more. We've got a baseline where we rank reasonably well across the southeast of England, but we still need more GPs because there's quite a significant cohort who probably will retire over the next 5 to 10 years, and we've got to make sure that we maintain that. But the key thing is maintaining the junior doctors who are training. So how do you retain them? You've got to incentivize them to come and make sure we kind of look after them. They can stay in the area. They can afford affordable housing for them. We've got GP fellowship schemes, which will help them to, give them confidence and in their first 5 years of post training, and fellowships and kind of other training opportunities and so forth, and specialties. And a lot of the junior doctors these days want flexible working, so we just got to be smart about kind of how we think. The traditional GP who kind of came to a surgery and stayed for 30 years is gone. Kind of new young GPs today want portfolio careers, and we've got to make sure we cater to that so the job is attractive and the workload is attractive as well, and kind of, as Sarah and Helen alluded to some of the things that are in the contract about making that work for healthcare professionals. So it is an attractive kind of opportunity. So we are recruiting, but Helen, I don't know if you want to add to that kind of where we are.
I mean, I think that's right. I mean, our GP numbers in Wokingham benchmark quite well in terms of the region, and also Bob. There's one or two practices where they're slightly lower, although obviously you get a different skill mix in different practices. I would just say, I mean, the ARRS workforce is a real focus for us in terms of building capacity, but we've got an equal focus on recruiting and retaining GPs. It is tricky for the reasons that Abid has outlined, but we've got, and Abid's also mentioned, a number of very different programs running consecutively, really focusing on creating new types of role, retaining some of the senior GPs, and really making our practices an attractive place to work. So absolutely focusing on that, as well as broadening out the primary care workforce.
Beth, next.
You've presented quite an upbeat story, but I have to say it doesn't feel like that on the ground. Our Facebook pages in Woodley are continually full of parents complaining that they've been hanging on from 8 o'clock in the morning at the doctor's surgery for 45 minutes, and that's not good. I have a colleague who is almost 80, type 1 diabetic, who hasn't had a face-to-face review since pre-COVID. So that's not happening. And so the the upbeat thing of progression that you're talking about doesn't feel real to me, I'm afraid. I don't like to say that, but I have to, because that's what our residents are facing.
Yeah, and you know, we're not here to kind of, we know it's a challenged situation. We know that's why there was the recent access and recovery plan the government had put together. So we know it's difficult for all the reasons outlined. There's significant issues. We're not trying to sugarcoat anything. What we're, I think, trying to say to the committee members and provide some assurances that there are a number of things that are in train, we hope, will improve matters for our communities and patients, you know, and I know how frustrating it is when you're hanging on the line and, you know, you're 50th in the queue, or actually you get to the 10th and the phone call drops out. It's not acceptable. Simple as that. So I think all the kind of things we talked about will certainly improve the situation. I'm hoping over the next 6 months or so, you know, we're going to be asking our practices to put together their plans. As Sarah's outlined, we'll be reviewing those. There's going to be a significant amount of support, investment coming down from the government. So there's a lot of effort going into this. This is number one priority nationally and for us. And, you know, we're really keen to make sure we can do our best, but it's going to take time. You know, these things, it will take time to resolve. And there's a number of factors there. Well, the kind of, you know, but we're confident that, you know, with everyone on board now, we can get there. And there's other things as well. So, for example, urgent access on the day. You know, we don't want patients bouncing into the Royal Barks or another acute hospitals or going into A&E. And we really want to manage them in the right place. So we might need to think, if there's not enough capacity, perhaps in the primary care kind of GP community setting, then what do we need to do differently? How do we need to commission that? How do we need to move resource? You know, what do we need more of, you know, surge centres, urgent treatment centres? We need to just think differently. And we've got a number of ideas that we're going to be discussing with the GPs over the next couple of months to think, what can we do differently? What can we put into place which is sustainable and long term? So we're not just scrambling around every winter trying to think how we're going to sort this out. So you're right. Yeah, it's not all rosy. But certainly, I mean, the telephone issue you've just mentioned, hanging on the phone for 45 minutes with a digital solution, that shouldn't happen. So I work in a large practice with over 20,000 patients. So we've introduced, it's been about a year now, and digital telephone systems, and we've got a callback system. We can do analysis on what's coming in. We can see what each patient care advisor is doing, where we need to move capacity, how we need to move our kind of staff in a different department onto the phones in the mornings that are answering them. But patients shouldn't worry in our surgery now. You can ring up and you can just press the callback option and you will get called back throughout the day, or by the end of the day. If it's non-urgent, you'll get called back. Your issue will get sorted. But if it's urgent, you can stay on. So that means that those patients who have an urgent need and want to get seen in the morning in our urgent clinic, even when all the appointments have gone, you will get seen. So, but obviously there comes a point, you know, you can only do so much, you know, and there comes a point where capacity obviously is full. And we, you know, as a backfall, we do have a safety net through 111 who can also advise. So yeah, trying to provide some reassurance, but yes, you're right. It's not all sorted.
Can I come back on that, please? My first question is there enough money in the system to recruit the new staff that are needed, whether they're GPs or nurses or other professionals? And actually, 111 is worse. You can hang on to 111 for 2 hours and still not get anywhere. And I can tell you that because I've done it. And in the end, you give up because it's not worth it. So 111 is not your solution.
No, you're right. It's not the solution. It's more of a if yeah. So 111 is being looked at as well. I think there's a re-procurement exercise going on for 111, and that'll be commissioned hopefully in a much better way and with more clinical input as well. So it's not kind of algorithm kind of admin based. As to the finance, always a difficult one. There is a large pot of money for the additional roles reimbursement scheme, the ARS scheme. Wokingham, as outlined by Sarah's, you know, doing well, spent significant amount of that budget. This is the final year of that, so we need to make sure our practices are utilising that for all the kind of additional clinical staff, non-clinical staff, to get those colleagues in. So we need to make sure that budget is spent absolutely, and that's what we're liaising with practices on. So yes, for all those additional roles, there's a significant amount of investment that's gone in over this 5-year period. across the whole of Berkshire West. And clinicians and nurses, and that's a matter for individual practices. So, you know, where there's vacancies, they should be actively recruiting to those vacancies as well, or planning for retirements.
So I think just important to note, Abid, that the ARRS investment is now recurrent. So we've been given assurances around that because it was an initial 5-year tranche of funding. So there will be continued funding for those roles going forward. And as Abid said, whilst 111 is a sort of backup, we don't really see that as part of the core model. What we want to get to a position is that practices are able to meet people's demands and needs on the day that they contact them, and that we have appropriate support services around our practices if needed, in order to ensure that people's needs are met on the same day.
Saying that because I can see, Doctor, you're still in your blues.
I was duty doctor today, so I didn't realise. I thought I cleared my diary to make sure I could get to the meeting, but someone had rotated me as the urgent care doctor of the day, so I literally was dealing with emergencies and then shot kind of. So yeah, so probably got a few things to tidy up after this meeting, so yeah, that's fine.
I'm very pleased that all three of you are on this call, because I have some requests actually. The first request is, I always like to understand the financials, so maybe next time you can present what the budget is for Wokingham PCN networks. The second thing is, you were talking about meetings and comms with, meeting with the WBC planners around the local plan, etc. And I know Rebecca has mentioned the Arborfield situation, which is not good. But there was also another offer that I was aware of to the previous CCG, which was a free site in Montague Park, which wasn't taken up, even though that whole area is another SDL where there's going to be significant new houses. So we see, can I call them missed opportunities? Could somebody from HOSC, I don't really mind who it is, get an invite to the meetings that you have with the planners so we can find out what's being discussed and find out what sites they're talking about? Because the HOSC does not know. And unless we get an invite to those meetings, I don't think we'll ever know. The final request, we've had, and me personally, I've had a lot of complaints about the Woking Medical Centre and Woos Hill access to services. And recently, Woos Hill was sending a generic email saying, "We look at, give us 1 month to send a reply to an email." And Madeline tries to schedule these meetings in the forward plan, and we requested meetings with the PCNs, the surgeries, and we were most interested in getting the most challenged GP surgeries into a meeting with us, and we identified those as Woking Medical Surgery and Woos Hill. They declined to participate because I guess they were busy or whatever. But we would still like you, all the people on this call, to use your leverage to invite Woking Medical Centre and Woos Hill to a meeting with us so we can talk about our residents' feedback and what people are saying locally. That's, the final request from my side. I hope you can make that happen because, we see in Woking Medical Centre is my area, but I think there's something like 25,000 residents and increasing on that single GP surgery, and I don't think it was really intended to be 25,000 people in one surgery. So we would like some answers from the people that are facing the customers, as it were, from Woos Hill and Woking Medical Centre. I think that's all the questions and requests from our side. I know it's a really challenging area, and thank you very much for your time. Always appreciate it. We ask some tricky questions, and but we get prompted by our residents to ask tricky questions. And I think we're all in the same ball game, and I think we're all pushing in the same direction. So thank you again so much for your time.
Thank you very much, Chair. Thanks.
Thanks, Chair.
Thank you.
Thank you. And I think we've got Health Watch next. Is Alice there?
Yes, I have.
Lovely to see your smiling face again, Alice.
It's nerve-wracking standing in front of y'all. So good evening, everyone. Good evening, Chair. Thank you very much for having me. I see you all have my report of what we've been up to, and as is there any questions from it? If you want to ask, please do, because I think a lot of it is very clear of what we've shared today. I mean, as I said, recruitment is still going on as volunteers, and in fact, one of the things that I would gladly share is that our board members are now also will be representing Health Watch in many other boards as well, because they feel that they are happy to represent and have a voice. And we continue to increase Health Watch presence. And the reach out to you all is please do invite me to any of the events that you have or my team, so that we can share what we are up to as well. Because one of the things that we want to do is increase our visibility. You mentioned about Enter and View, about working in medical center. The report is going to the practice manager and the clinicians soon, which is on Monday. We are physically presenting it to them to get a response, because they have to respond within 20 days, because there are some challenging information in there that we would like an answer. And we would like to present that in the next HOSC meeting in September. One of the things that I did mention last time was the fact that we put out a survey in April to the public, and through different platforms, and we had 127 responses, and the public had asked us to look at this as a priority. So GP services access, GP services quality, NHS dentist, accident and emergency services, adult social care, and ambulance services. So the board and I are looking at what our work plan is going to be for 2023-24, and we've highlighted this as GP services and qualities, which by the public understanding of the new way of working. So as I alluded earlier on to Sarah and her team, is the fact that I don't think the public is aware of the new way of working. In fact, we did a test of, we are sort of asked the public, what are the priorities in the, what are the important things that you want to understand about GP access? And the things that came out was registration, getting appointments, and also seeing a GP. So we have been trying to work with the PCNs to see whether we can improve the understanding of the public. Maternal mental health, I mentioned last time, which is part of the Health Watch England national report. That's still going on. We are in conversation with the primary care to find out whether we can improve the access of women to at their 6 weeks appointments, whether mental health is a discussion. And in fact, I'm also talking to public health to see how we can make this better for our women in Wokingham. Dentistry is still an important topic which we get a lot for, but we'll be focusing on pregnant women, and because we've found out that pregnant women are still struggling to get appointments when they are entitled to it. And also we are looking at people with learning disabilities, their issues with dentists as well. And then continue to recruit engagement, community engagement volunteers as well. And one of the things that came out in Wokingham priorities was looking at adult social care and ambulance services, and we are going to explore those comments to see what part of the adult social care they want us to look at, and which part of the ambulance services is an issue. Our watch list is still the same. Nothing has much changed as such, except for this year we are planning to look at women's health, possibly looking at maybe looking at how women deal with menopause. But this is also a priority for Health Watch England. Cost of living is also becoming a topic of concern because of the impact on prescription and attendance to hospital and attendance.
Thank you very much for that overview, Alice. Do we have any questions for Alice?
Yep.
Bill.
Hi again, Alice.
Hi.
Just one thing you've mentioned about pregnant women taking advantage of the services of dentists while they're, sorry to jump on Adrian's favourite subject, but taking advantage of services which are available free. Do you know the largest population in this area who have entitlement to free dentistry are children, and actually they are at the root of many of the issues which affect later on.
Mm-hmm.
So I just wonder if you could please just tack on to the end of there education for parents of young children in the area, and where the opportunities are for them to have these regular checkups for their children, because I think that that's something we just cannot miss now, because we'll reap it all in 20 years' time.
Will do. I mean, I think that's something that I think a lot of people have looked at as well, because I think young babies are not even having their checks as well within their year. So yeah.
Any further questions for Alice? Alice, really look forward to your report on Woking Medical Centre, which I think you said will be September. That will be helpful to everybody that's interested in Woking Medical Centre. You obviously heard that I requested from Sarah Webster that they turn up and present to this committee, because we have a lot of complaints about Woking Medical Centre, and we want to hear from them why there are so many complaints. Perhaps we know some of the answers already, or perhaps we think we know some of the answers, but we want to hear it from the horse's mouth, as it were. But I really look forward to that report, and I look forward to our next meeting in September. And if there's no further questions, I would like to say thank you very much, as always, Alice. Lovely to see you, and look forward to seeing you again.
Chair, can I just say something? Sorry to interrupt. It's just to say that when we meet the Woking Medical Centre, this is going to be a request that I will put forward to ask him to come to the HOSC if that's possible. But also, when you alluded to the Woos Hill issues, what I would appreciate is if you all could share those concerns with us as well, because we don't hear much about Woos Hill apart from what's shared at HOSC. To be honest. So if you do have concerns, do share with us.
Yeah, well, one of the residents in Woos Hill said to me that he sent an email to them recently, and he got an auto reply saying, we reply to emails in 1 month, so you'll get an answer in a month's time, which, he felt it was a more urgent request than a month. But the feedback from Woos Hill residents that I've heard is all the same things as Woking Medical Centre. So it's registration, it's access to GP services, it's all the same things.
Okay, thank you.
Please go ahead.
I do have one comment about Woos Hill. Previously, I'm a type 2 diabetic, and Woos Hill used to normally notify me around my birthday that I should have my yearly checkup. This year, nothing happened. And I went, okay. I finally had to call them to get it set up. My other half is also type 2 diabetic and doesn't seem to be they're not doing preventative care, which they really need to do to keep people healthy. So they don't need more GP work. it would be useful to have that happen. That's a comment back to them.
Okay. Thank you. I will.
I'll just add on to that because I'm a customer of Woos Hill as well, patient of Woos Hill, beg your pardon. And I can't speak highly enough about the practice and them contacting me for my making sure that man is working tests and blood tests and all the other checks. So it clearly there are some areas that work well, some areas that don't work well, and I think it's just about understanding where they are so that they can streamline the way that they deliver stuff, because it seems that there must be some differences in the way that they do these things. So Alice, just take it away that not everyone is dissatisfied with Woos Hill, but that doesn't mean that the story ends there.
I'm not dissatisfied with Woos Hill, but I just think that some things are falling by the wayside. That's all.
I think in a lot of ways, I think we could say a lot for most surgeries too. So there's some good practices, some are challenging ones, but I think, but please do share your feedback, then we can go from there.
Thank you very much, Alice, and see you in September.
Thanks.
Bye-bye. So the next item is a forward plan. Do you want to share your screen and talk?
So for our next meeting in July, we currently have the update on dental services. I'm just going to talk it through. Which is a follow-on from the meeting that you had in January, so we'll be inviting dental services back. We currently have the autism strategy listed, but we won't be able to take that item to that meeting because the officer is unfortunately not available, so we will have to defer that. Was there any other items that members wanted to suggest for July? I would suggest that dental services is going to be quite a big item, so you might want to do perhaps one other item.
Closing of pharmacies. The smaller pharmacies are being closed, and even some of the ones in this big chain stores are being closed as well. Like I said, Lloyd's is completely pulled out of all of the Sainsbury's, and that leaves a lot of places without any pharmacy whatsoever within their area.
Well, Boots in Woking Town used to be a massive pharmacy, and now it looks like it's being decommissioned. There's almost no staff, and it's almost lights out. Ingrid, do you want to interrupt us?
No, at all, thank you, Chair. It was just to add to that perhaps if we do talk about pharmacy, it will be David Dean who comes to that, who's the chair of the local pharmacy committee, the LPC. He might also cover, Madeline, the LPC footprint has changed from Berkshire West to Thames Valley, so we're going to lose some of that sort of close attention potentially. I don't know exactly what the plan is, but we might get him to explain that to us as part of that piece. And we can do that in conjunction with him. I can get public health consultant to come and just talk about the pharmaceutical needs assessment we do around looking at the need of our residents for pharmacy provisions.
Thanks, Ingrid. Beth?
If I could follow on from that, both to Rochelle and Ingrid, the problems in Winnersh have thrown onto Woodley. Woodley, of course, is without a Lloyd's too, so it leaves Boots and Day Lewis, and Day Lewis are at cracking point. They are so rude if you go into the shop, and residents are reporting standing outside for an hour or more waiting for a script to be done. Not good enough. We need to look at it. So Ingrid, it would be good to have someone in our next meeting to talk about it in more detail.
Will do.
Thank you, Ingrid. Anybody else for any more? I mean, for the forward plan, I'd like an item on the PCNs, Woking Medical Centre and Woos Hill, but it doesn't have to be a near term, it can be mid-term. I think if that's all for the forward plan, then we can close the meeting. For everybody that's online, thank you very much for your attention. look forward to seeing you at the next meeting. Thank you very much, everyone.